Good evening. Good evening. I have to say I didn't expect to learn something about my hometown in this session today, but we do have some curated questions for you all. But before we get started, I did want to give our panelists just a little bit of time to talk about their organizations and what they do, because I think that'll help frame our conversation and the work and the community work that we're going to talk about today. So, Dan, if you want to get started.
Yeah, thank you. So Daniel Lettenberger Klein with Stella Maris. Stella Maris, for anybody who doesn't know, many people don't know, is the oldest addiction treatment provider in the state of Ohio. We've been on the same block since 1948 in Ohio City, right on the West Flats. And we provide every level of addiction treatment services from inpatient withdrawal management all the way through housing. Take care of a little over 5,400 people a year. What's unique to us and why community is such an important component of what we do is 85% of all the people in outpatient care live with us that we take care of. So it's a unique housing model where people are staying with us 5, 6 months, sometimes up to a year, to make sure that they have all the resources and the opportunities to do well, to thrive as they go back into their communities.
Bill?
I'm Bill Finn with Hospice of the Western Reserve. We serve about 2,500 patients every day, either in our hospice program or in home-based palliative care. We'll serve somewhere around 22,000 people this year across 18 counties, and our goal is really to help people with serious illness stay home and be as well as they can as they're on their journey that will end with their passing. We do adults. We have a specialty pediatric program as well. And we do a number of grief-related services that are part of that community social safety net, including postvention counseling with the City of Cleveland School District when a child dies. So a number of other things that touch our core service lines.
Dr. Alexander?
So I feel like probably most of you know the Metro Health System, but just to kind of give a little bit of a refresh, we are the safety net hospital for Cuyahoga County, but really service a great deal of Northeast Ohio, either through our Level 1 Trauma Center or rehabilitation services or other services. And really our mission is to take care of everyone regardless of their ability to pay. And that's wide-ranging, from primary care services to specialty services, to inpatient care and onward, as I mentioned, rehabilitation care and so forth. So really feel a deep commitment to being a part of the community, and how healthy the community is a mission that we take very seriously as well, and really honored to be with people here that we partner with on a regular basis and couldn't take care of our patients in the way that we do without these two critical organizations.
Thank you. And as Dr. Bias shared, my name is Dominic Hobson. I have the pleasure of leading Neighborhood Family Practice, which is one of 5 federally qualified health centers that we have in Northeast Ohio. And our organization is primarily positioned on the west side, similar to Dr. Alexander, accepting all patients regardless of their ability to pay. And we serve about 22,000 patients each year across a number of different services. But with that being said, we're going to go ahead and jump in. And so, Dan, I want to start with you. What is the level of commitment from your organization to community health, and how is that commitment carried out into communities that you serve?
Thank you, and thank you for having me here today. This is a real honor to be here with all of you. Stella Maris's commitment to the community has been a significant part of the mission since 1948. So we opened in an effort to take care of the longshoremen that were coming off the boats in between seasons and trying to get well so they could go back to work, go back to their families. And so since the beginning, Stella Maris was never about sticking its head up, talking about what it was doing. It was always just taking care of the neighborhood, which was historically an Irish Catholic neighborhood, but has really evolved to a regional treatment provider. So every day on our campus, you'll find people from all over the region coming with varied presentations, unique experiences, but really ultimately most are coming Medicaid dependent or uninsured. Many have come from jail recently. Many are unhoused or recently unhoused. And so trying to create stability in their presentation is a case-by-case situation for us. So when everybody shows up, Stella, it's really triage for us in a different sense than a hospital setting, but where we're just surrounding around the client, each client and their family system, to make sure that we resource and provide them the best opportunities to thrive in community, whether that's getting plugged back into housing, jobs, education, training, whatever that may be. We tend to also be the primary provider for a lot of the unions in the region as well, so highly skilled labor, to make sure people get back to work and keep building things. So our goal is to get people back to their families and their jobs, but community health is our primary focus to make sure people get well and return back home.
Dr. Alexander, do you want to add to that? I know there's few organizations that have a deep commitment to the community as Metro Health, and we'd love to hear you talk about some of the work that you all are doing and how that presents from a community perspective.
Sure, thank you. You know, being a safety net hospital, you just automatically assume that you're really good at the community piece, and truly over the last maybe 2 decades, we've been even more intentional about that, of thinking through, you know, how do we define community, how do we get our care out to where people are instead of just waiting for people to come to us. And so a piece of that is growing our network of outpatient health centers that were, you know, strategically placed in places where we knew people were struggling to get access to care. But then really started thinking about that in a different way. And the school health program is an example of that, you know, we noticed kids weren't coming in to get their vaccinations, get their well child care, et cetera, did a deeper dive and decided, let's just go to where the kids are, and thus the birth of the school health program that has now become a national model. And, you know, just thinking in other ways about, you know, care for the homeless. So we now have a mobile unit that goes to homeless shelters. So really just trying to think ahead of what's the needs of the patients and how are we best meeting those needs, whether it's through creating these mobile clinics or, you know, going into existing structures, to say, okay, if you can't find your way to us, we're going to find our way to you and make sure that we keep you as healthy as possible. Again, with that idea of a healthier community is a productive community.
Thank you. Bill, you want to add anything to that?
Just to say that in our space, which is people with serious or chronic illness, but may have years to live, the same underlying purpose exists here, that our goal is to meet that patient on their journey. A lot of the work we're doing right now is also geared towards veterans that are experiencing the end chapters of their life and recognizing that a veteran today is fundamentally different than a veteran from 20 years ago. And how do we realign our delivery of services to be able to meet their needs and their families' needs? So it's a constant evolution of how we present to patients and families what they need to get them through their journey in the best way possible. And just a lot of, it's all community-based work in terms of what we do. So whether it's veterans or pediatric patients, it's being present without regard to whether there's insurance or not. And if it means meeting the homeless veteran under the bridge and creating a plan to make sure they don't die under a bridge, it's being there when they need us most.
Yeah. Thank you. So I'm going to stay with you, Bill. What is the healthcare executive's role in community health, and how do you lead change?
That's a loaded question, isn't it? Think about it.
Nice little softball there, right?
Yeah, yeah, the 98-mile-an-hour pitch. So we're all not-for-profit here, and I think that has really colored my 43 years of leadership, where I feel that we have an obligation to change the world we live in, to be influential, to be impactful. And I remember when I was a kid, my doctor, my parents' doctor, made an effort to call them at night to make sure they were okay, to do these things that demonstrated, boy, he was my parents' advocate. And one of my great concerns about healthcare is, who's your advocate now? Who has your back? And I think we have a shared obligation to speak for those that can't speak for themselves, to assure that the care that everybody gets is the same care we want, and to help build that infrastructure. So I think we all have a shared obligation to be an advocate for our community. to speak up wherever you are on the healthcare spectrum, political spectrum. We need to be able to have venues like this and others where we can make sure this community's needs are really well understood. And personally, you know, it's engagement at the federal level, the state level. It's finding those opportunities through boards and other linkages where we can try and be strategically influential.
And thank you, Dan. I would love to have you pick up on that,
Yeah.
especially in the sense of the outward-facing work. Historically, there's been so much stigma around mental health or substance use, and you just touched on getting our tradesmen back to work, our tradeswomen back to work. Can you speak to that a bit?
Yeah, I think ultimately, you know, an organization like Stella that is not huge, a massive system, it's really been an intentional forward-facing goal from the board down to the leadership to make sure we show up in the room. If we're not in the room, decisions are being made for us, and those decisions impact the lives of our clients. You know, we've been and are still in, you know, an interesting wave of a devastating opioid epidemic. And so our job is to show up and say the thing and continue to say the thing and coordinate the care and make sure that a client at Stella Maris is a client at Metro, is a client at hospice when they need to, is a client at neighborhood family practice when they need to. So I think that's the role there. As it pertains to stigma, absolutely having that government relations component and an education initiative when you're educating legislators, the people that are making decisions that impact access, the ability to provide the care, but also the conversations that are happening from the school and beyond in the family home. And so for us, when it comes to stigma, that's why, you know, we think of ourselves as a community center for recovery. We have 44 recovery meetings a week on campus and 120-seat auditorium and a community coffee shop. We want to be the place you go if you want to learn anything about recovery. Even if you don't know something about recovery, come get a good cup of coffee, and maybe the person next to you might be 1 week in, might be 1 month in. And that's how we address stigma. We normalize, we create space, a place worth being for the community, not just for those in recovery. And for us to address stigma, and as a leader trying to address stigma, it's making sure that every community turns into a recovery community, because a recovery community in and of itself can be its own vacuum, where we want to make sure that everybody knows how to help people thrive around them.
Yeah, thank you. Dr. Alexander, I want to come back over to you and ask who within your organization is responsible for community health?
So in thinking about this as we had been chatting, really it's every single person in the organization. We really, you know, kind of back to the next question of, you know, how does it happen at the executive level? It really is at the executive level, kind of setting the tone and role modeling and saying this is our priority and this is what we're about, and here are our ideas of how we think we're going to get there, and that cascades throughout the organization. But there is also, it's not just a one-way communication. It bubbles up from the people that are really doing the work every day. And I think when I was that person on the front line doing the work every single day, I felt like I had 1,000 things I wanted to share, and I wasn't really sure how to share it. And you know, how do I create change? So, you know, we just started kind of doing it at the local level, and we figured it's easier to ask for forgiveness, and you know, but I think now we have that we're creating is the people on the front lines have all the knowledge and the patients have the knowledge. And so really it is every single one of us gathering that data, that information, and putting our heads together and saying, hey, here's the path forward. So, well, we're setting the tone at the top. We're also listening to people doing the real work and having that be the two-way street. And that's where change can really happen, when you get those fresh ideas, where you understand what your community is struggling with and what their needs are, and how we can then start to say, okay, how do you want us to meet that need, and then making it happen. So it truly is every single one of us.
Thank you. Bill, you want to answer that at all?
Yeah, I would say again, our space is a little unique, and the same type of stigmas that exist in mental health, drug recovery. If I was to ask all of you, what does hospice mean? most people would say, oh, you're very close to dying. And we have an obligation to kind of destigmatize that word because it scares so many people. And today, 1 out of 3 of our patients will be with us for less than 7 days. And if I was to ask you how many of you would like to die in a hospital or a nursing home, we know what the answer is. And then I couple that with asking you, what's the most expensive segment of a patient's life? The last 6 months of life. So we have this opportunity and this responsibility to try and align to what patients want, to die at home, to be comfortable, to not have fragmented care, to be able to have the space and the grace to do all that important work, to say, I love you, thank you, I'm sorry, please forgive me. That takes a lot of work to get there. So we need to be on this journey with patients. And for many patients with, like, for example, the work we did with Metro Health around minority patients with congestive heart failure, we were able to prove with Cleveland Foundation funding that we can fundamentally change their experience and not have them die in a hospital. But it took us working together and creating that approach and understanding that don't be scared of the word hospice. And we're here to really create what we all want in terms of how we exit this world whenever that happens.
Thank you. So we started the conversation really talking about our commitment to community health. But one of the key things is, especially our board members, our funders, they always want to ask, how do you measure that impact? Which is very difficult to do from a community health perspective, but I'm still going to ask them a question on that. So Bill, I'll stay with you. What has been your outcomes from your organization's role in improving the health of your community?
So there's a number of outcomes. Of course, there's the star ratings that we use to compare ourselves. We actually compete with about 120 hospices. The vast majority of them are for-profit. We actually have some private equity hospices here in Ohio, and their goal is a little bit different than ours. Ours is to provide return on community investment, to demonstrate the money that we took in, we used for the good of our community, not to make a profit. So certainly the quality scores, the ability to serve everyone, and to have that continuum to say wherever you are and whatever your illness is, we'll be with you. So again, it's the specialty programs like pediatrics, the veterans program. It's the ability to do the things that are huge loss leaders, like the grief care. You may know some of our inpatient units we have around the state. There are no for-profits in America that have an inpatient hospice unit because you lose so much money on it. But these are all the ways we create that ROI for our community. And then again, part of our contract with our patients and families is grief support for at least a year after the patient has passed. And that's a very rich and robust program that goes far beyond what is mandated. But it's really important to give everybody the tools to continue their lives and be able to have that grief be manifested in a positive, supportive manner.
Yeah, I would love to hear from both Dan and Dr. Alexander. So Dan, if you want to start, how do you measure your impact from an outcomes perspective on community health?
That's a very difficult question for us because we're in our infancy of measuring, right? Like in behavioral health, it's grown out of such a lay-led type background that it doesn't have a lot of legs related to measuring outcomes. We look at national standards in terms of what we do. So Stella Maris in particular has completion rates that are 20 to 40% higher across every single level of care. We think that's due to the community impact that we have of creating community on site, modeling community. But then we look at not only the numbers served, but we think about the ripple. You know, when you do the work that Stella Maris does, you're not just sending somebody back to a building or a job, you're sending them back to a system, right? Which is the people they work with, the family they come home to, the children they start taking care of that they haven't been able to, the parents that they're able to care for, right? So there's all these ripples that happen when we think about impact that are hard to measure. But in terms of other components for us to think about community impact is not just the number of people we bring in through meetings and care and all these other pieces and parts, we know that if somebody goes through our withdrawal management, which is our highest level of acute care, we have an 89% success rate of having them do more than one level of care. If they only do the highest level of care with us, we've failed. And so by setting our own standard of what success looks like for us, for somebody on their recovery journey, we're able to hold ourselves accountable. And then we know that when they move through the full continuum, culminating in leaving our housing, 87% of our clients are in school or have a job at the time they complete that, and 100% have housing, which is an unreal statistic when you think of like the housing component, but it's in a collaboration with Cuyahoga County and working with the sober housing network that's been developed. So impact looks a lot of different ways. Unfortunately, what's a little different too with the recovery world is that success looks very different for different people, and everybody has a different path towards recovery. Many recovery stories and journeys involve relapse. And then there's a family system there to navigate that relapse as well, and the shame, failure, all those components. So there's so many different outcomes that can be either a slice in time, longitudinal, but we really like to think about the impact we have in the ripple, and we think about that when we think of impact.
Dr. Alexander?
So I think it can be really difficult to measure the impact because you often are left with things like counting things. You know, okay, we had this community event and here's how many people came. You know, here's how many people were screened at this. You know, here's how many people that came to the mammogram van and got their mammogram, right? So sometimes you're just kind of counting things. And so we really lean into what are their real outcomes and drilling down. So the quality outcomes, and we look at common disease states and how we're doing with managing those disease states and comparing ourselves to others, hospitals that are similar to us, but, you know, across the country, national databases and so forth. And we look at things like, you know, patient experience and so forth as well. But we then take it a step further, and the example I'd like to tell you is around breast cancer screening, that you know, the guidelines had changed and recommended, you know, patients be older when they screened. And so we just started tracking this and said, actually, you know, we have this population of patients that you would categorize as underserved, either because of lack of insurance or, you know, salary, et cetera, et cetera. And we said, wow, these patients, when they come in, they're coming in with advanced stages of disease. The biopsies are showing advanced stages of disease. And that really shouldn't happen, because by national standards, you should have a whole bunch of biopsies that were just negative. So we're like, all right, what's going on here? And really tracked it back and said, these patients need to be screened younger because they are a more at-risk population. And so we changed our own standard of screening before the national guidelines ever changed, because we were tracking our outcomes with our patients. And because of the dashboard that we had, we were able to really drill down to say, okay, this at-risk underserved population, we need to do something better for them. And so we changed our guidelines, which now other women are taking advantage of, because we completely changed and we used this modeling and all of that happened because we were really trying to say, how are we taking care of our community? And so we can do that around a number of other things, you know, diabetes management, high blood pressure, et cetera, et cetera. But we really try to track those quality outcomes very, very closely so that we know we're providing the best care we can for our patient populations.
Thank you. I want to stay with you, Dr. Alexander, and kind of put a little bit of a twist on that same question. But how do you measure community benefit? Or do you see those similar or different? I know we hear a lot in the community about uncompensated care and how the different organizations are measuring how much care and a hospital system is providing. But can you talk to that one at all?
Yeah, and it is kind of nuanced, right? Because when people think about benefit, they think about dollars and cents, right? How much are you providing? And you know, right now, where we're at, we're providing about $1 million a day in uncompensated care. And that uncompensated care looks differently, that for some, maybe they have, you know, a marketplace plan that's a high deductible plan that they couldn't afford to pay. And some of them are patients that are eligible for maybe Medicaid, but had trouble signing up, or et cetera, et cetera. So it doesn't all look the same, but what it adds up to, by the end of this year, will be somewhere in the ballpark of $350 million to $360 million in uncompensated care. So when you think about how are we caring for the community, how do you quantify it? What's the benefit to the community? It is that we're continuing to provide this level of care to patients who need care, and figuring out the finances on the back end, and thinking about how do we innovate and how do we continue to provide this care given where we're at right now at this point in time. So when you think about benefit, I think that's where a lot of people go to, are the dollars and cents of it. And then back to the idea of counting things up, right? How many patients are seen at these particular sites or at these particular events?
Bill or Dan, either you want to chime in on this one. How do you see the difference between community impact and then community benefit, especially in the context that Dr. Alexander just shared?
So I think we share a community benefit goal of having our patient, our client, be able to return to a place where they're fully contributing to society. Maybe that's the goal we're looking at here. So for us, it means that we have a family that isn't overly burdened by the loss of a loved one. They're not traumatized to the point where they're pulling back from their normal, healthy life, that folks are able to move forward. It also means there's a lot of hidden nuance that doesn't really get seen in terms of recognizing one person's imminent death in a family has that ripple with everybody there. And if it means, we just had a woman whose daughter would have been guardianed by her parents, and her dad was a pedophile. So we had a very small window to get the guardianship set up. There's things like that that happen every day with all of us to make sure the trauma impact is minimized, the ability to return to community service and wellness is the priority. And I would say that maybe it's community wellness. How do we raise that up one patient, one client at a time?
I think it's really been beautifully covered. I think for us, the benefit, is similar to the impact in that, the people that come to us, we think of, the mental health and addiction component, right? Through how do we stabilize a community? How do we create an opportunity for people who have maybe grown up in a family system where everybody was dysregulated, right? It's just a traumatized family system for generations. Our goal is really to slow stuff down and reset things. And so when I think of community benefit, it's not in the traditional dollars and cents way that it's measured. It's not in the economic impact of how many people we employ and how many people we send back to work. Those are great numbers, right? Those numbers matter, and politicians want to hear them. But for us, that benefit is what kind of change are you creating in your community that leads to a better outcome for the next generation? And so for us, we think of our benefit being this is kind of an inside joke at Stella, but if you've ever been to Stella Maris's coffee shop or the campus, you'll see people wearing SMU gear. And that stands for Stella Maris University. And our clients typically didn't go to college. Many of our clients, some did, but many of our clients did not. And so, especially the younger generation would be tied into that like failure to launch population, especially with the opioid epidemic. And so the piece with the SMU gear is like they came here to learn life. They came here as that next step. So we want to launch them just like they would launch from college into their career, into what they want for themselves, and define that for themselves. Because everybody that leaves with intention, purpose, and well-being creates community benefit, right? So for us, we don't need to market because every person doing well is the best marketer we have. So community benefit for us is stabilizing that one person that helps stabilize the community.
Yeah, thank you. We've been talking about how our organizations impact the community, so I want to turn things around, and I'll start with you, Dan, and just speak to how the community has directly impacted your organization or changed your organization, right? We've been talking about changing community, but we all know that many times the community changes us. So can you speak to that?
Yeah, I think Stella is a really neat example of that because we've had to respond to every drug trend and alcohol trend, just like an ER would. But since 1948, right? So in the beginning, it was all alcohol. In the 70s, we got hit with the heroin wave. Then we've seen opioids through the pain pills, and then heroin, and then synthetic opioids, and now a resurgence of crystal methamphetamine, and alcohol since COVID has had a massive resurgence, and benzodiazepines being a massive issue. So Stella has always had to evolve with what was hitting the front door. You either saw it in our front door, the ER, or the morgue. Those are the three places you're going to see the drug trends. And so for us, we never had a good business plan. It was just doing the next right thing to take care of the person that was at the door. So today, having the infrastructure, the psychiatric infrastructure to take care of a more acutely psychotic population with synthetic opioids has been a necessity. We don't have the funding mechanisms in place to support that level of care further on in the continuum into outpatient. It wasn't built for that. So we're adjusting with what we're seeing at the front door, making sure that that triage is powerful enough to be impactful and stabilizing, and make sure that whatever trend we see, whether that's a medical presentation, whether that's a family system presentation, whether that's a social determinant of health opportunity for us, that we're thinking through how we respond to build not just the service lines, but the wraparound services and the ancillary care, so that our clients come in and get something different. Because our motto is, if not here, then where? And I'm sure the hospital and the hospice, all of us operate that way. So if not here, then where? We got to step up and do the work.
I would love you two to answer that also. But Dan, before we leave you, you talk about how your organization is set up to do that on a continuum, after the initial needs are met. How are you building those collaborations and partnerships and handing off to your partner organizations that you're working with?
Yeah, I think we're trying to get better at that. For us, it was so much of like the case manager gets the referral to the place and we hope they show up, right? That is not a system of care, right? That's how people fall through the gaps. So for us, it's really about coordinating from the moment of admission. Our job is to start discharge planning the moment we see them. And so for a level of care, an organization that you can be with for 6 months to start discharge planning from the day you get there, we get pretty good at it. And so making sure that we have an idea of what their course of care will be based on their willingness, never based on what their insurance benefit dictates. We're able to really make sure that we tailor through partnership with Neighborhood Family Practice, Metro, all of these different organizations that do exceptional care. When you come to Stella Maris, you'll see the VA bus on our campus. We take care of veterans and have had a long-term standing relationship with the VA. So you've seen Care Alliance vans on our campus. We've had the mobile mammogram bus on campus. So our goal is to make sure that they leave with a plan, and that plan doesn't start when they leave, it starts before they leave, so that they have all of those relationships built, because you don't worry about disappointing somebody you haven't met yet. Right? So the idea is that we want those relationships, some of that feeling of obligation, that feeling of necessity to go, to be built and set up with a support system around them so that they might follow through. And then we want to keep them tapped into the recovery meetings so we can hold them in check, right? The recovery world is built on accountability. That's what 12-step models are with sponsors and sponsees. We model that and build that and help support that system so that they can integrate into the community partners, because if they just stop with us, we've failed.
Yeah, Bill, I would love for you to take that question, but also in addition to the community impact in your organization, I would love to hear how some of the other, either private equity funded or for-profit organizations in your industry has changed your organization.
Sure. So over 50 years, a lot's changed in how we live, how we receive health care, where we receive health care, and how we live and how we die. So in 50 years, we've seen so many families that used to be extended families now are nuclear families. And the number of patients we have that are live alone, or where the primary caregiver is so compromised by their own health, comorbidities, age, whatever it may be, that we've had to create artificial families and supports to help people stay at home in very fragile environments. That's been a big change. The number of patients that have 10 or more comorbidities is unbelievable. So we're dealing with very clinically complex people and using resources and technology now to create the ability for them to stay at home safe and be well. So it's also informed us in terms of who our clients are, how we support them, how we link with other caregivers and resources. And the thing we're all working real hard on now is how do we create the next generation of caregivers? Because we just don't have enough people coming into nursing and medicine and the other skilled trades to support all of us as the baby boomers begin to retire. We know we're going to push care to home. That means we lose the efficiency of having a floor of a hospital where you can see lots of people, but we really have to rethink the way we provide care. And again, all of us want home to be the location of our care in the future. So that's really what we're aligning to. In terms of the competitive factors, bring on the competition, but can we at least get rid of the fraud and abuse? Can we cut out the really bad actors? We have programs that beyond cherry picking, in the state of Alabama, for example, 47% of all people admitted to hospice are discharged before they die because they're too expensive or too difficult to care for. That's disgusting. That's wrong. We make that commitment to be with the people through their journey. We have a lot of cherry picking. Most for-profit hospices primarily care for people with dementia because they don't cost a lot and they don't need a lot of care. How do we change this here? One of the things we've done is create a statewide network of nonprofits, community-based nonprofits, and try and bolster up those smaller nonprofits that they can thrive, they can care for their communities. We're not going to see them go under and national chains come in and use their revenue model to really get the most out of a community and leave the least behind.
Dr. Alexander, how has the community impacted your organization?
So there's so many different ways that we have the opportunity to interact with community. We have a fantastic community relations department. I can't say enough good about them and being out in the community and truly listening to the community, interacting with the community. We have our Institute for Hope, which is our institute that really is meant to address those social drivers of health. I think you all probably know because of what you do that 80% of a person's health is not determined by the office visit or, your interactions with the healthcare system. So the Institute for Hope is meant to kind of address that 80%. And so in doing that, you have structures set up that allow you to really more deeply interact with the community and then bring back information to the institution to say, okay, here are some of the things that we need to be thinking about and working on. And back to that idea of kind of the tone gets set at the top, but the people that are doing the real work day to day, listening to them because they're the ones seeing the trends and they're the ones that know what's going on. It's understanding what's coming at your front door. It really is the people that are caring for the patients, the physicians, the nurse practitioners, the PAs, the physical therapists, and all of those folks. They have the information, and so they start noticing the trends and they start bringing it forward. And then I think it really is connecting with your community partners and understanding what's going on with them. And I joke a lot, but I say I work for the county hospital, and I can get 13 cents out of every dime. And the way I do that is by partnering with other people that are doing the work that we need, that our patients need, and I figure out how to partner with them, and then we share our resources, and that's how. And so it really is also listening to our community partners and hearing their feedback and figuring out, okay, this is what we're faced with. How do we problem solve together? So it really is very, very multifactorial how we get the information from the community and then be able to turn it around into something that's meaningful for them.
Thank you. All right, we're going to pivot. And Dr. Alexander, I'm going to start with you again, with you being attached to a county government. But we'd love to hear you talk about how do you open dialogue with local leaders and discuss assessing the health of our community.
Health. Mm-hmm. So we receive funding from Cuyahoga County, and so that's why I think people see us as, and I just said it, of course, myself, the county hospital, right? So we're the safety net hospital, and we receive a stipend from the county government and put that toward the care of the uncompensated patients. So that sets up just a natural opportunity to interact with the county government. And in fact, just earlier today, we were meeting with our county representatives and walking them through, what we're seeing at the hospital and information on financials and charity care and so forth. So we have very, very regular dialogue with the county, and that one is, of course, the easiest because they're right here, right? And then you start thinking about, okay, how do we interact if with local officials? How do we interact with people in the state? How do we interact with people that are working in the federal government? And really, I'm a family doc by training. I think everything happens through relationships, So really, it is so vital to open up dialogue and have relationships with people that just begin with a simple meet and greet, right? Here's who I am, here's who I represent, and here are some of the things that I think are common to us, because I think beside the relationship you have to have some commonality and have common priorities. And no matter who you're meeting with at the state level or the federal level, they're there because they're invested in their community, right? So just figuring out that sweet spot that exists between the two of you, that is that common priority, and really trying to then grow from there and to be able to say, okay, you want healthy, productive communities. We want healthy, productive communities. How do we create that together? And here's where I'm struggling, and how might you help? And where are you struggling, and how can I help? When I met one of the newly elected officials in DC, that was my first question. How do I help you? What's important to you? How can I help you from where I sit as a healthcare institution? And so really, understanding that they have things that they're struggling with. They have people that they have to answer to. They have goals they have to hit. And so how do we partner to do that together? So it's not just, hey, I'm knocking on the door with my hand out, but how do we truly, deeply partner? And I think that's the easiest way I found to open those conversations and create that foundation.
Bill and Dan, we just exited a very interesting legislative cycle, both at the state and federal level. We'll love to hear both of you chime in on picking up where Dr. Alexander left off. What are you all doing to engage with leaders to make sure that you're bringing forward what your community needs, but also trying to solve the problems that they see that are most important for them?
It's been a hustle since, it's just been meeting after meeting, going down to Columbus, up here. We don't do a lot of federal work other than some relationships that we built, that we keep people updated and keep their ear to the ground. And if you ever want a high pressure situation, testify before a Senate committee, because you got 3 minutes on the clock and nobody's really listening. They might be jotting, it's wild. But so I think one, relationship matters. It cannot be based on budget cycle. You have to have the relationships in place throughout the year, building those relationships, cultivating that time, figuring out what matters to the elected official and what platform they care most about, because making it worth their while, having them sit down and say, how can I make the best use of your time? I value your time. How can I make the best use of your time? And then that walk away is how do I make you how do I help you accomplish your goals? Whether that is helping you write policy with a narrative related to behavioral health. How do we make sure that you understand what's happening on the ground floor? What due diligence and what research can I provide for you with the rooms you're in? And then at the same time, the back ask is, can I be in the room? Can I get in that room? Can I help create space for the dialogue to talk about what's happening on the ground floor? So it's a rapid hustle and a long game at the same time. It's maintaining those relationships continually while always tying it back to what they are willing to and what they are interested in, passionate about, will show up for, and not just in election cycles, because it's different, right? So it's just all understanding the cycle, making the most out of the opportunity, and knowing who you can call when resources are necessary.
Yeah, you're exactly right. You know, at a time when civil discourse is so challenged, we have this issue of how do I bring forward things that may be popular to half but not the other half? How do I do that? And it comes down to what we said. What we're bringing forward is relationship and the joy and wonders of this community. That's what gets us to a common playing field and puts apart the politics for a minute, and then speaking to what we all want. You know, we all want health, safety, and go through the list. But bottom line, it really is, have you established long-standing relationships with all the key representatives, and then also asking your other constituents to help you with that. You guys know the most powerful thing you can do is bring a client with you, bring a patient with you, where you're allowing them to tell their story and demonstrating the value that was created and the importance of this service. So I would suggest that we all have a role with advocacy, but we also have a lot of untapped resources we can use to help tell our stories.
Thank you. So we've talked a lot about our elected officials, but I would love to go back around one more time and talk about local leaders. We saw during the pandemic how important our faith-based leaders were, but there are so many other local leaders that are critical to our success. So Dr. Alexander, can you start and then speak to how you're doing in managing those relationships?
So I'm glad that you brought that up. We have a council that's made up of local pastors. And this is huge for us, because if you want to know what's really happening in the community, talk to somebody's pastor, because they know exactly what's going on with every single member of their church, because they're there supporting them every step of the way. So that's been just super helpful to us. And we also have family counsel through our patient experience office. So we have, family members, patients of our system that give us real feedback and, give us suggestions and help us to develop ideas and problem solve and so forth. And it really is a matter of staying in touch with the community directly, but the people who can speak for the community and aren't afraid, to say to us, that's really not working, or no, actually that's not so bad. You might think that you're really struggling with this, but no, that's not what people are saying, right? So those type of relationships are really super important. And I think just thinking about all of the other stakeholders to be able to say, hey, how are you dealing with this? Or is this what you're seeing? I talk pretty regularly with the other health system CEOs, to really just have that opportunity to say, okay, what are you working on? And, how are you doing it? And here's what we're seeing, and here's what we're thinking about. It just is incredibly helpful. And I think if we stopped seeing ourselves as competitors in this space and view ourselves as collaborators in this space, I think that makes a huge difference,
Yeah, I would agree. We serve 18 counties, so we have 18 plus different groups of folks that see their neighborhood, their city, their county as their loci, and Knox County, Ohio feels very different than Cuyahoga County, and their needs are different and their hopes and goals are, but there's a coming together that can exist when we do this well. You have to listen, you have to respond, you have to engage. We need to find pathways where their voice is heard and they feel like not only are we listening, but it's this concept that touches DEI, that they feel like they have a belongingness with our program, that they're wired to us. It makes a difference because we were there for them before, we're listened, we're engaged, we'll be there for them when they need us in the future. So, and, don't ever let a closed door be the end of the story, too. We've had so many places with it asking for money or trying to get support from some level of government or whatever it is, and it just takes that constant churning of effort. But I have to say, this community is pretty remarkable in terms of trying to say, how do we get to yes? And I love that.
We at Stella do a faith-based leaders summit because behavioral health is a unique challenge, especially in the communities showing up at their churches and temples. And so we work with faith leaders to help them have the conversations, what to look for. So we want to help them feel more confident going back to their communities and helping, and then knowing that they have us standing behind them to help support their community. We do the same thing with the construction community. We have construction leaders, we have legislative receptions. We try to bring different groups in because behavioral health is a little unique, and not everybody understands what behavioral health is. That addiction and mental health are behavioral health, and how that works together. And then the other thing we do, because not many people understand behavioral health as much as they might understand what a hospital does on the surface, we got to get people on site. People have to see what happens on our campus to really get it. And when we get, especially elected officials or any local leader on site to walk through the space, to see the faces, to see how somebody maneuvers through, how somebody thrives there, that it's really in the shadows of every tall building down here being right over there, that's when the conversation changes, the investment changes. And then, Mary Ann Crossley, who's a former CEO of the Cleveland Leadership Center, started everything with leaders show up. You got to be at the stuff. You got to show up to all the things, because if you're not in the room, the conversation is going to happen. And so when it comes to leaders, regardless of whether they're elected or not, being in the position to be at the table, to be in the room, to say the thing, to educate people, but also to invite them in and show value is invaluable. And so she would say all the time, leaders show up, and that will prove itself invaluable time and time again.
Yep. Well, sounds good. And so I have this question highlighted to make sure that I wanted to get to it. We're in a market where especially our hospital systems are led by physicians. All right, I consider myself an administrator. In many of our rooms that aspire to lead healthcare organizations are not clinical or not physicians. So Dr. Alexander, I wanted to make sure to ask this question, but how do healthcare executives work with physicians in order to improve the health of our community?
So I feel like this one's a chip shot, right? Being a physician. And I kind of stacked the deck with physicians as part of the executive leadership team, because I felt like it was really important to have people that truly understood what it meant to put the patients first. And every physician that is in the executive suite actually still sees patients, myself included. So I just felt like that was absolutely critical, because the physicians, and this goes really for any healthcare provider that are on the front lines, they want to know that we're not just sitting up in the executive suite eating bonbons and watching reality TV when they're here trying to really make patients healthy or keep them healthy or save their life or do the hard work with them. And so I think, what speaks volumes is saying, I'm still one of you, and I'm here to feel what you're feeling and to see what you're seeing and to partner with you. And if you're an administrator and you don't have that opportunity, and I spoke with someone recently who was retired who said, well, I couldn't deliver the care, but I made sure I would go into the OR to watch what was happening and to ask questions and to say, what do you need that you don't have right now? And I would go into the office and I would go to the bedside. And it's what we call leadership rounding going, but just really being there so that you have those opportunities to partner. But we set up other structures so that our executive leadership team now also includes our president of the medical staff and our president of what we call the council of chairs, the chairs of all the different academic departments, just to make sure that everything we did was really inclusive of the folks who are providing direct health care, and that they had that seat at the table and that they had had, the power to speak up and to course correct and to tell us when we're wrong and to push us along when they think we're going in the right direction. So I think those opportunities are really, really vitally important.
So just to build on that, I'm not a doctor, but I am a home health aide, and I did that purposefully. So usually on a Saturday night, I will work the night shift in one of our inpatient units as a volunteer, and it kicks my butt. But the insight and the understanding of both our patient's journey and also our staff's journey is amazing. And I would put a home care aide up against a doctor any day in terms of understanding the issues and concerns and challenges that patients and families have, because they're living it every day. So I think it's for each of you, all of us, to find what is that insertion point for you where you can tell a story that brings you close to what you're doing and moves you out of your C-suite and gives you that personal ownership and allows the optics of those you work with to say, they get it. They know what we're doing.
I'm a marriage and family therapist by training and licensure, and I had worked at every level of care before I got into leadership. And so I had a unique take on it, but my entire career has been spent with physicians and nurses. I'm very fortunate for that. And so for me, my job is to kind of get out of the way and resource. And so Stella is unique in that it's one of the largest teaching institutions for medical providers in the region when it comes to addiction medicine. So we're partnered with Metro on our addiction medicine fellowship, UH on the addiction psychiatry fellowship, Case Western's first year medical students all sit in outpatient psychotherapy group. The second year residents all round through detox. And then PA students come from Case as well, every major nursing school in the region, and clinical students as well. So it is a place of learning on campus. And so my role with the physicians and not being a physician-led organization is really to make sure that we're not only providing the care that our clients deserve, that the community deserves, but that we're educating the next generation of provider so that they can launch, whether they stay here, which would be amazing, I hope they do, but if they don't, that they know what good care looks like. They know what, we try to set the standard that everybody aspires to when it comes to community-based behavioral health care. And so we take the physician-executive education relationship very, very seriously.
And thank you. How are we doing?
A quick question about community health and pop health are sometimes talked about as the same thing. I've been in healthcare 42 years. The question that's been nagging me the last 20 of those is, should pop health be done with the hospital leading? Given the fact that the hospital is a health care, acute care facility, should it be done with hospice or done with behavioral health, or is there something else? What else can we do? I mean, I've looked at Camden Coalition, De La Raza, and other structures. So I live in Northeast Ohio. I'd like the community to be well-served, high school diplomas, things get done, but should it be a hospital as a leader or something else?
Who wants to take that?
All right, I'm going to take a stab at it, especially because you mentioned the Camden Coalition, right? I think it's very natural for it to be linked to, community health, to be linked to a hospital, because truly it can be hard to pick apart what is population health, right? Looking at specific populations and how do we best care for that population, whether that's a disease entity or another demographic sort of statistic, right? Versus public health, right? Versus community health. Because to my mind, community health is a little bit different because it encompasses many other aspects, right? Education, safety, all of those things do impact your mental health, behavioral health, physical health, but they really have slightly different focuses. And so I don't think that the healthcare system needs to own it, but certainly needs to be well engaged in all of those things. Yeah. Yeah. Yeah, yeah. Well, it's interesting. We do track data around like grade point averages, seat time, graduation rate, those sorts of things. What percentage of the kids actually finish certain immunization series? What percentage get their recommended screenings through Well Child Care? But we also started tracking for teenagers every single visit, suicidality, depression, anxiety, substance use, because we noticed that trend. So I could tell you exactly how many students were seen and where they fell on those parameters. So there is data that we do track, because we really try to say to the school that this is worth your while. You know, we are pulling them out of the seat to come for the appointment, you know, but they're not going to miss a whole day of school because they had to go for a doctor's appointment. So, yeah.
And I do think it is both end. I think we have to follow the dollars, first of all. That is how a lot of this flows through. But I think it's those communities where they're able to bring together a larger group, and this is the purpose of WellLink, to be able to create a community where we can couple all this talent to really be actionable and change our communities in a very positive way. So the potential's there. It's going to take all of us working on that.
Yes.
Yeah. We'll go here. I'll just say one point. Thank you so much for that question. The one thing that I struggle with sometimes is I feel like we're working in silos. People are focused on economic development, economic mobility,
Yeah.
and in my mind, you can't do any of those without health. I don't care how many jobs we bring to our community. If our community isn't healthy, they can't work. They can't sustain. They can't support their families. So I think we have to make sure that we have the right people at the table and we're measuring the right things. But great question. Okay.
So Dominic, maybe you can go a little bit further in that conversation piece. So I know one of the speakers spoke earlier about health inequity that exists in our community. And that is rooted by institutional racism. So I'm eager to hear from all of you, all three or one of you, how you are confronting racism in your organization to make sure you get some of the root cause of inequity that exists in our community.
Yeah, I'm sorry, did you want to go? No. It really can be challenging. And so this is one of the reasons why we track our data so closely, and that we really slice it and dice it to say, well, okay, you know, back to the breast cancer example, you know, at first blush, we were like, well, the screening guideline says, you know, 50 and above, blah, blah, blah. Oh, look, by our statistics, it looks like we're doing pretty well, right? Women are getting screened when they should, and congratulating ourselves. Yay, we have the mammogram van, and it's going out, and it's doing its thing, and we have breast amigas, until we said, let's really do a deeper dive into that data. And that's when we realized that Black women and Hispanic women and those women that lived in poor neighborhoods were not getting screened adequately because they were the ones coming in with these really aggressive forms of breast cancer at younger ages. So that speaks to some of the structural racism that can happen along the way, right? But you have to be willing to really challenge yourself as an institution to say, we need to look through many different lenses to actually see the whole picture, and you have to really step into that to do that hard work, so you then can create the programming that best meets the needs and creates that equitable health outcome for our patients. You know, when we look at a lot of our data, we're able to say if we can get them to the Metro Health system, we can actually create equitable outcomes because we look at it through many different lenses.
I think first you have to own it and say, this is our responsibility.
Yep.
You have to look inward and say, are we where we want to be in terms of percent of board members that represent our whole community, our staff, our leadership? And then we also have to take a step further. And I will tell you, I was really surprised when one of our African American aides said, you know, the scariest place for me is in a white suburb at 3 o'clock in the morning when I'm visiting a patient, because I can get pulled over and I'm not going to be necessarily treated fairly. We had it happen. She and I went and met with the chief of the police, and he told us why they do profiling the way they do. He owned it. He said, yeah, we do that. And I can't imagine what that feels like being a privileged white guy, and I could drive through any community and not feel like that. So there's so much work. There's no quick answer here, but I think it is when your organization takes diversity, equity, inclusion, fairness seriously, and you make that apparent in your wage structures, in your management and leadership structures, and you own it and talk about it, and sometimes you have to say, I'm sorry, I made a mistake, but you own it and try and be a better organization.
For us, it's a big data piece for us to review and look for trends to make sure that our trainings can be impactful. One of the things we did early on was look at compensation, the way that people were compensating their employees to make sure there was equity in that process and that everybody had level footing. We looked at hiring practices, who were finalists in every role. We looked to make sure there was diversity in that piece as well. But when it comes to like there's a number of other things we do, but when it comes to the specifically racism for those that we're taking care of, for us to be able to feel like we're giving everybody an opportunity to thrive, especially minority populations that have historically experienced just dramatic effects and just devastating effects of racism for generations. Our goal is to do financial literacy with the people that live with us. We want to provide housing resources so that they can work towards home ownership and tag them in with like habitat. Make sure that while they're with us, we do all the things with legal aid to work on expungement clinics. We get them connected to the OB care that they may have never received before they got to Stella Maris. So we're trying to address a lot of the elements that have come out of racism, that have led to inadequate care, disconnect and lack of safety and trust in healthcare systems, in government entities. And so that's really where our case managers thrive, is addressing a lot of those systems that are in place to make sure that the resourcing is done. But there's a number of other internal mechanisms that we're looking at to ensure that we hold ourselves accountable, like making sure that the people that we hire reflect the people we care for.
Yeah, we got one right here. If I know you don't have a mic, but if you want to raise your voice.
Jeff Hallam, Kent State University, and I wanted to mention that as a public health professional, my definition of community health is vastly different from the people sitting on this panel. And it's the interprofessional nature of what it is that we do. And in that context, one of the best demonstration projects that I think should be modeled actually is in Tallahatchie County, Mississippi. I spent 14 years working in the Mississippi Delta, and the work that has been accomplished there in taking the 81st out of 82 counties in overall health, community health, and how it's measured, it's now ranked 61. 10 years. So it took a decade, but looking at high school graduation rates and employment and all of those other issues. So from a model of what we can do to influence community health, when I was there, we attenuated childhood obesity. Childhood obesity started to decrease. So there are models, there are programs, and particularly this demonstration project that is attached to a regional hospital. But it's set aside from that, and funding obviously is an issue. So there's a benefactor, the James C. Kennedy Foundation, CEO of Cox Communications, who has ownership in Mississippi. But with the money that Jim has put into that program, and then HRSA grants and other projects, but this is a project that could be modeled and taken to scale. Now, yes, it's a rural community, but we're pretty rural wherever you want to look. But to take that to scale, so there are models out there from a community health perspective that can vastly improve community health.
Yeah, thank you for that feedback.